Hello, everybody. Here we're going to talk about hypothyroidism. This is super important because there is some basic science here that's going to be relevant for you, not only for step 1, which is obviously a basic science test, but also on step 2 and 3. And they're not going to test you on the nitty-gritty of the basic science, but when it comes to making these diagnoses and getting labs and interpreting those labs, it's going to be really useful for you to have that understanding of the basic science because it'll cut down on the memorization that you would otherwise have to do. So this is really important stuff, and I'm going to try to keep it short, but it's important that you understand this, so I don't want to skimp here. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions I can get to help offset the cost of these videos, and I thank all those of you who have already stepped up to donate. I appreciate it very much. So this is what we're going to talk about. We'll just do a brief overview with some physiology and symptomology of hypothyroidism. We'll talk about how this tends to show up and what we do to work this up. I'll give you a little algorithmic approach. Always helps to kind of know organizationally how this is approached. We'll talk about the major cause of hypothyroidism, which is in the US, Hashimoto thyroiditis. We'll talk about an emergency that can arise from hypothyroidism, and that is Myxedema coma, and then we'll do a recap. So hypothyroidism at its very basic level is a reduction or insufficiency of thyroid hormone. And there are two thyroid hormones. One is T3, that's the most active form, and it is a minority of the thyroid hormone. And then there's T4, which is the majority of the thyroid hormone that you have. Both of these we can measure in the laboratory. However, we tend to measure T4 more frequently than T3 just because there's more of it and it's easier to measure. So most T3 and T4 are bound to something called thyroid binding globulin, which is a protein. Thyroid hormone is not water soluble, so it needs to be carried by a protein. Now, as it's bound to thyroid binding globulin, it is inactive. So often we will measure free T4 because that is the active T4. If you measure total T4, that could work, but there are certain conditions, namely pregnancy or if you're on oral contraceptives, where the thyroid binding globulin increases and consequently we increase the amount of thyroid hormone. And so you have the same amount of free T4, but your total amount of T4 is high because you got to make up for the fact that you have higher thyroid binding globulin. Okay, so the symptoms of hypothyroidism, it's useful to know because when we talk about hyperthyroidism, the symptoms are kind of going to be the opposite. So thyroid hormone is responsible for increasing your metabolic rate. So if you have low thyroid hormone, you're going to have a reduced metabolic rate. That just means how active your body is. So if you have a reduced metabolic rate, you're going to have some fatigue. You're going to be intolerant to cold. So these are patients who are going to be shivering all the time. Maybe they're going to be wearing a sweater on a hot 85-degree summer day. That's Fahrenheit, by the way. Weight gain despite poor, that should be normal appetite. So weight gain despite normal appetite, they're eating the same amount, but they're gaining weight. Important to look at their previous weights when they were in the clinic before. If they have a weight gain, you want to ask them, what's your diet like? Constipation, bradycardia, decreased deep tendon reflexes, and hair loss. They can also get a painless goiter. So this is going to be an enlarged thyroid, but it's not painful. It tends to be rubbery in texture. Hyperprolactinemia can develop due to increased thyroid releasing hormone. Remember, that comes from the hypothalamus. So if you have a decreased T3 and T4, that's going to reduce negative feedback in the hypothalamus, and the consequence is going to be you'll have a high thyroid releasing hormone. Not only is that going to increase thyroid stimulating hormone at the anterior pituitary, but it is also going to increase prolactin. And as a consequence, you can get galactorrhea, particularly in women. And remember that prolactin plays a role in the menstrual cycle. So they can get disturbances to their menstrual cycle, amenorrhea, and menorrhagia. You can get deposition of glycosaminoglycans. That can result in myxedema, which presents as a pitting edema, hoarseness due to edema of the vocal cords, and pretibial and periorbital edema. And then hypothyroidism can cause some psychiatric issues. In older adults, it can cause a pseudodementia, which is almost indistinguishable from Alzheimer's. That's when we suspect Alzheimer's. We always get a thyroid hormone level. And then in younger adults, it can cause a depression. So always important when you have a patient coming in with poor mood, you're always going to get a thyroid hormone level, a TSH level, to exclude hypothyroidism. Both hypothyroidism and depression are very, very common. Now, primary hypothyroidism is where you have a problem with the thyroid. And so there's nothing wrong with thyroid releasing hormone, with thyroid stimulating hormone. The problem is with the thyroid itself. So the thyroid is not releasing thyroid hormone. You have low thyroid hormone in the blood, and so you have less negative feedback, and so your TRH and TSH are going to therefore be high. All right, so loss of negative feedback. So you get that thyroid stimulating hormone, it comes back high, you're likely dealing with hypothyroidism. That's kind of counterintuitive, but that's the way it goes. Now, secondary and tertiary hypothyroidism are problems with the pituitary and the hypothalamus, respectively. So in this case, you'll have a low TSH, particularly if you're dealing with the pituitary, which is usually where it's at. And then you'll also have a decreased thyroid hormone level, of course. Now, the number one cause of primary hypothyroidism, and by the way, primary hypothyroidism makes up 95% of hypothyroidisms in general. Number one cause is Hashimoto's thyroiditis, and that's the number one cause in iodine-sufficient regions like the US and developed countries. There are a variety of other causes. It can be drug-induced. There can be other thyroidities that we will talk about more when we get to hyperthyroidism. It can be iatrogenic. If you remove the thyroid, you're certainly going to have a hypothyroidism, and so we need to supplement those patients with levothyroxine. And we would do this in patients who have either a thyroid cancer or they had a hyperthyroidism that we had to resort to a total thyroidectomy. Iodine deficiency in the developing world, most common cause of hypothyroidism, and then it can be congenital as well. Secondary and tertiary hypothyroidism is only about 5% of cases, and this is commonly due to a tumor. And so if you do have a secondary or tertiary hypothyroidism, you want to CT these patients to see if you can find a mass. There's something called euthyroid 6 syndrome. I'm not going to get into this, but you can look it up. It's not commonly tested. And then the complications of hypothyroidism include hypercholesterolemia and myxedema coma, which we will go into. The most common chief complaint of hypothyroidism is unfortunately very nonspecific. It's fatigue. They come in, I'm tired all the time. Maybe my mood isn't that great. You might think depression. Again, get that TSH. It'll help you differentiate other causes of fatigue or poor mood from hypothyroidism, because hypothyroidism we treat completely differently than depression. But there are a number of labs that you want to get. One of them is a CBC. We're looking for anemia. Anemia is a big cause of fatigue. Unfortunately, some of the causes of hypothyroidism can also cause anemia. So what you may see here is a normocytic anemia. However, if you're dealing with a young woman, and a lot of these patients are women, particularly Hashimoto's, you may see an iron deficiency anemia or a microcytic anemia, and so you would want to work that up with iron panel. So that's important to get. You want to get a BMP, of course you want to get a TSH and free T4, and then in their history, you want to go over some things. You're dealing with fatigue, you want to know what's their sleeping habits like. How many hours a night are they getting? If they're getting 5 hours a night, Oh, that's probably sleep deprivation. If they're getting 10 hours a night and they are taking long naps and they're overweight, think of possibly getting a sleep study for obstructive sleep apnea. Of course, like I said, we're going to be getting the TSH no matter what, but you should know how to work up a patient with fatigue because this is the most common presentation for hypothyroidism. Look at the weight changes, get an endocrine review of systems, all going to be very important. All right, so how do we approach this algorithmically? Well, if you have suspected hypothyroidism, I'm just going to put hypo there, you want to get a TSH and a free T4 all the time. Now, if the TSH is normal, then you want to consider other alternative diagnosis. If the TSH is elevated, then you want to look at that free T4. If the free T4 is normal, then what you're probably dealing with is a subclinical hypothyroidism. Okay. I apologize for my crappy doctor handwriting. If the free T4 is low, then this is primary hypothyroidism. And the number one cause, remember, is Hashimoto. And we'll talk about how we further work that up, but it's with an anti-TPO antibody. Now, if you are getting a TSH that is low, then what you're probably dealing with is a secondary or a tertiary hypothyroidism because you're not stimulating the thyroid. At that point, then again, you want to look at the free T4. And if the free T4 is low, then you are dealing for sure with a secondary or a tertiary. You're going to CT these patients. If the free T4 is high, then you're not dealing with hypothyroidism at all. You're dealing with hyperthyroidism, and you want to work that up. That would be unusual to have a hypothyroid presentation with a hyperthyroid patient, but I'm just putting this in there for completion's sake. All right, Hashimoto's thyroiditis, number one cause in iodine-sufficient countries, and it is associated with HLA-DR3. You got to know that for step one. It predominates in females like most autoimmune disorders, about 10 to 15 to every one male patient. Average onset is 30 to 40 years. Again, autoimmune disorders tend to show up in younger women. And it affects approximately 1 in 1,000 people, so very common. Associated with other autoimmune disorders, as mentioned, lupus, rheumatoid arthritis, primary biliary cirrhosis are among the most common. It's mediated by anti-TPO antibodies and anti-thyroglobulin antibodies. The anti-TPO is probably the most important one. It's what you're going to get to work up on labs. The complications are hypercholesterolemia, anemia of chronic disease just due to the chronic inflammation, and hyponatremia. So these patients present with hypothyroid symptoms, as we already went over. They can have a painless goiter due to the inflammation of the thyroid. Rarely it presents with hyperthyroid symptoms. That's called hashitoxicosis, and we'll talk about that in the hyperthyroid section. That will, though, eventually move into a hypothyroidism. The physical exam should show an enlarged but painless thyroid. Of course, they'll have some of the other hypothyroid symptoms. The diagnosis, you're going to start out with that TSH level. It should be it should be high. TSH is going to be high because this is a primary hypothyroidism. And then at that point, once you have a high TSH, low free T4, then what you're going to get is the anti-TPO and anti-thyroglobulin antibodies. The anti-TPO is the most important one. And then once that comes back positive, you have a confirmation of Hashimoto's. The most accurate test is, of course, biopsy, but we rarely do that. This is a laboratory diagnosis. The treatment is just replacing the thyroid hormone and getting them euthyroid. We measure the TSH to confirm that. So we want to get that into the normal range. Very cautionary note, if you're dealing with an older patient with history of coronary artery disease, You should start the levothyroxine at a lower dose. However, some sources recommend surgically correcting their coronary artery disease. If there's blockage and they're candidates for CABG, then you want to consider doing that before treating their hypothyroidism. And the reason is because you can induce angina, unstable angina, even more significant problems. And the hypothyroidism is not so much an emergency. We can get them surgically managed and then start the treatment. So there's conflicting recommendations, so you'll probably not be asked about this on the exam. This is an enlarged tongue here, likely due to the deposition of glycosaminoglycans. You can lose hair, and certainly you can have a goiter. Myxedema coma is a life-threatening complication of hypothyroidism, usually precipitated by some kind of physiologic insult in a patient who's already hypothyroid and not treated. This can be due to infections, it can be due to physical trauma, it can be due to medications, even prolonged exposure to cold. The symptoms are the hypothyroid symptoms along with altered mental status. Now, despite the name, most patients with myxedema coma do not present with a coma. They present with altered mental status, fatigue, drowsiness, and so forth. The physical exam will commonly reveal hypotension and then, again, hypothyroid symptoms like bradycardia, hypothermia, decreased respiratory rate. That's more of a myxedema coma symptom. And there could be signs of effusion. The best initial step is the TSH level. Of course, however, when you've got a patient that's unstable, certainly the best initial step is to stabilize them. But assuming that they're stable, then you get the TSH level. It could be high, it could be low, depending on the hypothyroidism that you're dealing with. Usually it's going to be high. And then, you can get your free T4 and all that. Other labs to obtain, I bolded the most important one, finger stick glucose. Hypoglycemia is common in myxedema coma, and it's something that absolutely positively needs to be addressed. So you're going to get that finger stick glucose. It takes 5 seconds. You get it, and then you can administer dextrose if you need to. CBC may or may not show a high white count. That gives you an idea of the precipitating cause if there's an infection. BMP may show hyponatremia. That may need to be corrected depending on the severity. EKG may show low voltage QRS complexes, common in severe hypothyroidism. ABGs can show a mixed respiratory acidosis. And the reason that's important is because it indicates the respiratory status. You may also want to get blood and urine cultures, particularly if that white count was high. The treatment is immediate IV therapy with levothyroxine and with IV hydrocortisone. And there's a reason for that. You can look that up if you need to. It's complicated. I'm not going to go into it. Fluid resuscitation if they're hypotensive. Obviously, airway management. Be ready to intubate them if they show signs of respiratory failure. Warming blankets if they're hypothermic. A lot of times these patients will be sub 95 degrees. And then D50 is mentioned if they're hypoglycemic. You want to work these patients then up for the underlying cause, getting cultures, chest x-ray, EKG, cardiac enzymes, and a drug review. You can also get a cortisol level. Some of these patients may have hypocortisolism. There's some overlap there, and so you want to rule that out. The disposition, send them off to the ICU. They'll be monitored very closely, and that's going to be really important. So these patients aren't going to be sent off right away. Please note that T3 is only given if the diagnosis of myxedema coma is certain. Okay, otherwise we avoid that. So we'll give T4 instead. T3 can be kind of dangerous. So err on the side of levothyroxine. So to recap, hypothyroidism presents most commonly with unexplained fatigue, weight gain, dry skin, depression, and abnormal menstrual cycles. The best initial test is the TSH and free T4. With a high TSH and a low T4, we're dealing with primary. That's 95% of cases. The number one cause is Hashimoto's. Get an anti-TPO to confirm. Low TSH and low T4 is secondary hypothyroidism. That's usually due to a tumor in the brain. Get a CT. Treatment of hypothyroidism is levothyroxine, just replacing the thyroid hormone. Myxedema coma is a life-threatening complication. It presents as hypothyroidism with altered mental status. Best initial test, again, TSH and free T4. Very important to stabilize these patients. If there's respiratory depression, you may need to intubate. Hypoglycemia, give dextrose. Hyponatremia, you may give 3% NaCl. Hypothermia, you're going to give warming blankets. Remember, again, stabilize these patients. Look for the underlying cause. The empiric treatment, however, as mentioned, IV levothyroxine and IV hydrocortisone. These patients will be admitted to the ICU, and you need to find the underlying cause.